It's very exciting to see the evolving landscape in urothelial cancer, especially with immune checkpoint inhibitors. Right now we have 5 immune checkpoint inhibitors approved for platinum refractory advanced urothelial cancer. It's pembrolizumab, atezolizumab, nivolumab, durvalumab, avelumab, and one of them, pembrolizumab, has level 1 evidence based on the Keynote 45 trial that was published by Dr. Belmont and colleagues in New England Journal of Medicine a few years ago. And we have 2 of them, atezolizumab and pembrolizumab, approved in the frontline setting in patients who are not fit enough for cisplatin. They can get pembrolizumab or atezolizumab if they have tumors with high PD-L1 expression. However, in the US, the FDA allows the use of either of those 2 agents, atezo or pembro, if someone is not fit enough for any chemotherapy. If they're frail for any chemo, they can get pembro or atezo regardless of PD-L1 expression. And I think it's important to note that there is a plethora of combination clinical trials trying to build upon this success with immune checkpoint inhibitors plus targeted therapies, vaccines, cytokines, etc. Try to see if we can improve upon, even with chemotherapy combinations, upon the outcomes with checkpoint inhibitors alone. So definitely a significant change so far, and hopefully more to come in the future. The biomarkers is a holy grail. It's a big question in not only urothelial cancer, but in oncology in general. And we have tested different biomarkers, PD-L1 being one of them that has some clinical value in the frontline setting, as we mentioned before, in cisplatin unfit patients. And there is a number of other putative, promising biomarkers like TMB, tumor mutational burden, like immune infiltration, T-cell density, T-cell clonality and diversity, mutations in DNA damage response genes, DNA repair genes, gene expression profiling, luminal versus basal, as well as other potential biomarkers circulating tumor DNA, MDSCs, Tregs. All these biomarkers need to be formally tested in clinical trials in a prospective fashion and need to be validated. I think from all of them, TMB looks very promising, but I think, again, it has no clinical utility as of today in urothelial cancer, but definitely is very promising for more validation studies in the context of the ongoing clinical trials in the future. And the problem is that, biomarkers need to have validation in a prospective fashion and prove clinical utility before they are incorporated in clinical practice. It's a very good question because the combination of CTLA-4 and PD-1 or PD-L1 inhibitors has been tested in different tumor types. For example, we have data in kidney cancer, we have data in melanoma, and even in urothelial cancer, in platinum refractory disease, we had the previous trial that was presented by Dr. Rosenberg and colleagues looking at ipilimumab and nivolumab combination in patients with pretreated advanced urothelial cancer, showing an overall response rate of 38%. And this response rate was up to 58% in patients with PD-L1 high status in the tumor tissue. But this data is not practice-changing yet, but we have 2 ongoing large randomized phase 3 trials in the frontline setting, comparing, for example, the Danube trial, durvalumab and tremelimumab combination to durvalumab alone versus chemotherapy in an upfront setting. And also we have the Checkmate 901 trial comparing ipilimumab and nivolumab combination to chemotherapy, again, the frontline setting. So these 2 frontline trials, Danube and Checkmate 901, are going to define, in my opinion, what is the utility of the combination, the dual checkpoint inhibition, CTLA-4 and PD-1 or PD-L1 inhibition in urothelial cancer. And based on these studies, we're going to see also if we can have any biomarkers helping us select patients for the right treatment. Having said that, there are some studies looking at these combinations earlier in the neoadjuvant setting, and I think this is very interesting, but again, not practice-changing yet. We all have to do a better job educating the patients, the caregivers, as well as the providers, ourselves, our teams, and other providers, for early recognition and prompt management of immune-related adverse events. At the University of Washington and Seattle Cancer Care Alliance, where I practice, we have formed an immunotherapy-related adverse event tumor board, where we can actually discuss cases. Patients who have significant toxicity from immune checkpoint inhibitors, that we can learn how we recognize them early and how to manage them properly, and how can we utilize this data to inform future decisions in the clinic, because the data is not present for every single scenario. So we have to build databases, registries, and through these tumor boards, we can collectively develop experience of how to recognize and manage those adverse events. Because in theory, any part of the body can be a target of the immune system, and all these ITs, as we call them, can happen, at any point of time, usually early on, but it can happen later. They're more common with the combination therapies, anti-CTLA-4 plus anti-PD-1, PD-L1. However, we need to do, I think, a better job educating even the patients to report them, because some patients under-report. They're afraid to report the adverse events. And through this collaborative effort, tumor boards, registries, databases, and clinical studies, we can develop more data. We have some publications out there looking at this question of optimal management of adverse events, and I think collectively we can do a good job building this evolving infrastructure to anticipate, recognize, and manage those events, which can be sometimes, rarely, very severe. There's a number of very promising agents in advanced urothelial cancer, and I will just give you some examples, not an exhaustive set here, but targeted therapies. For example, we have erdafitinib, which is approved by the US FDA for metastatic bladder cancer with tumors having activating mutations or fusions in FGF receptor 2 or FGF receptor 3, fibroblast growth factor receptor 2 or 3. And this is a very promising agent with ongoing phase 3 trial comparing it in patients with those alterations to chemotherapy or pembrolizumab. So we're going to have data in the future, randomized trial data. But for now, it's available for our patients through data in a phase 2 trial that showed very promising overall response rate of about 30 to 40% with this drug erdafitinib. There's a number of other very promising FGF receptor inhibitors being tested in clinical trials. There are, of course, antibody drug conjugates like enfortumab vedotin against Nectin-4 with impressive overall response rate, about 40% in pretreated patients. And this agent, enfortumab vedotin, has a breakthrough designation, not approval yet, but we believe it will happen in the future by the FDA. We have data presented here at ESMO with the saxituzumab govitecan, the IMMU-132 antibody drug conjugate against TROP2, with a very impressive overall response rate approaching 30% in heavily pretreated patients. And then we have, of course, targeted therapies, as I mentioned before, PARP inhibitors being tested. We have other antibody drug conjugates against HER2, the DS8201 and other antibody drug conjugates that show data at recent ASCO meeting with promising and impressive response rates. And also we have combination therapies as well as biomarkers. We have combinations with checkpoint inhibitors and vaccines, cytokines, and epigenetic therapies that could try to modulate the epigenetic programming of the cell and could potentially combine this epigenetic therapy with immune checkpoint inhibition. I think through all these trials and the biomarker development, we're going to have some very interesting results in the future. An example of that was the BISCAY trial that Dr. Pauls presented here at ESMO meeting, and a trial by Dr. Hoims with enfortumab vedotin plus pembrolizumab. Very impressive data, and hopefully we're going to see more data in the future.